Thank you for joining us for the AAOF Clinical Podcast Series. My name is Dave Kading, and I practice in Seattle, Washington, and I am delighted to have Dr. Erin Rueff joining me today. Erin, welcome, and please tell us a little bit about you.
Hi, Dave. Thanks for having me. I'm Erin Rueff. I am currently at the Southern California College of Optometry at Marshall B. Ketchum University in Anaheim, California. I'm the chief of the cornea and contact lens service there and teach in the contact lens curriculum and do research and a bunch of other stuff. So,
yeah,
hello.
Erin, I want to dive right into this. We picked a really interesting paper here, Visual Performance and Binocular Accommodative Function of Stop Contact Lenses compared to the MiS lenses. Here's some interesting things here. We are getting inundated with myopia management information. It is so refreshing. But there's new lenses that are coming out, and they function a little bit different, and they act different than lenses that we have. We just are grasping how MiS is so amazing in its clinical and research information. But new lenses are coming out, and we're having to learn a little bit about them. So this paper talked a little bit about us. Just give us a brief little overview of what the paper is, 30 seconds or so.
Yeah. So this paper is comparing this sort of novel new type of contact lens design called STOP, a STOP design. STOP stands for spatiotemporal optical phase, but we'll just refer to it as STOP, of course, obviously. So, we know that MiSight is the first FDA-approved soft multifocal contact lens for myopia management. MiSight is going to cause peripheral defocus that sort of serves as no pun intended here, a stop signal for the eye to grow. Again, super exciting. It's a great tool for us to have for myopia management. What the authors of this paper note, however, is that with a lens like MiSight, there's usually an initial period of really high efficacy of that sort of slowing of myopic progression, but we tend to see a sort of adaptation effect. So sort of a plateau over time. And what the authors kind of hypothesize is that in order to continue to see, progressive stopping of myopia progression, maybe there needs to be a switch in treatments or perhaps a more dynamic optical stimulus that is going to kind of encourage the eye to stop growing. So this stop design has sort of it has a sort of, they described it as a meridionally and azimuthally varying power distribution. And I had to look up what azimuthally meant. I won't bore you with it, but it's basically just like a different type of angle on how light is entering the eye. And this type of design is going to cause astigmatic blur in the periphery. And notably, this lens is allowed to rotate on the eye so that blur is dynamic. So it's kind of moving around the eye. And in theory, again, that's going to be a different kind of sort of stop signal for myopic progression.
Yeah. It's almost as if you're looking at a topography and you're seeing a little bit of steepening superiorly, and that's how the design kind of looks from what I remember reading this paper, or the other design.
The figures they had were of the lens power profiles. The astigmatic portion was static, right? But again, they described that the lens was allowed to freely rotate on the eye, which would mean that how I'd interpreted that was that blur would sort of move around the ime throughout the day. And what they were hypothesizing is that that dynamic movement of the blur could potentially be a better, maybe different type of stop stimulus than like a MiSight lens that's more static.
Yeah, so an important component of this is that it would rotate and it would cause that maybe blurring in different areas. Give a little bit of an overview of how the lenses compared in the study for like comfort, vision,
so really the
binocularity.
The purpose of the study was sort of to compare these lenses to MiSight, which is sort of the gold standard in this case, right? And basically to see if, visually, comfort-wise, if there was a significant difference between the lenses. The authors mentioned in the discussion that they're, preparing to do a full-on clinical trial with this type of lens to see how effective it is in myopia management. And so this is sort of a first step to first say, hey, is it comparable to MiSight? Will our patients even be able to tolerate this lens? So they measured subjective visual experience. So, basically like the patient's opinion of the lenses, and also, objective visual acuity, high contrast visual acuity at distance, intermediate, and near distances. And really they found there wasn't a significant difference between any of those things. So I should say they compared two types of these stop lenses. One they called an f2 stop lens, and one they called a DT stop lens. They didn't include a lot of information about either of those. I got the sense that was sort of just two different flavors of these
Right.
stop lenses.
I like how you call it flavors.
Yeah, I mean, I tell my students, I have to simplify things down in my brain so I can understand it. So flavors, that works, it's like popsicle or something, right? Basically they found that subjectively that f2 lens had better intermediate and near vision than the MiSight lens. But the MiSight lens had better subjective near vision than the DT lens. But really overall, I would say there weren't compelling differences in subjective or objective visual acuity with these lenses. There were no differences in comfort, no differences in they asked the patients if they'd be willing to buy, either lens. Every participant wore all three lenses in the study, and there was no difference there. MiSight did perform slightly better at distance and near on high contrast visual acuity. But the authors noted that in previous studies, oftentimes MiSight has performed better kind of objectively, but subjectively not as well. And sometimes the subjective preference is more important. So a lot of data here in this study, but what I really walked away with was there wasn't a huge difference between any of the lenses, sort of like a one factor here, one factor there, but not a marked difference between the lenses.
So if we found out later that there was as an effective treatment or, maybe a superior treatment in some way, that you'd feel comfortable patients going in either direction based on this preliminary data.
I mean, based on this data alone, it was a small study, only about 28 participants. But yeah, I mean, I think this is when you're testing a new type of technology, this is a first step, right? And trying to say, is this something that would be realistic that we could trial with our patients? Even if you can show effectivity in myopia management, if a patient can't see well or doesn't like it or isn't comfortable, it's not a good treatment option, right? And so, this is a good first step. I'll be curious to see, clinical trial results of, how effective it is in the actual management of myopia.
Do you think it has any potential based on what you saw here? But maybe?
I mean, here we're not actually looking at things like axial length or myopia progression, right? We're looking at mostly subjective experience with the lenses, which is important. It's really important. But yeah, I'll be curious to see, from a axial length and refractive error standpoint, if these lenses are able to influence myopia progression in a similar way that a soft multifocal or an ortho-K lens can.
Yeah. Fantastic. Any closing thoughts? Anything we haven't touched on yet?
Yeah, this is just a good reminder that this field is changing all the time. When I saw this title come across, I kind of said to myself, what? Stop lens? Is this a blind spot for me? And so it's a good reminder to us as clinicians that, just stay on top of the literature, keep your eyes and ears open to what's happening and changing, because, this is just a really, dynamic field. We were talking about dynamic visual stimulus. It's a dynamic field, and there's always new stuff out there. So good to just make sure you're always staying on top of the latest evidence.
That's absolutely perfect. Wonderful. Thank you, Dr. Rueff, and thank you for joining us for this episode of the American Academy of Optometry's Foundation Clinical Podcast Series. Make sure to like and subscribe, share with your friends. We'd love to get more information out to more people, so make sure to let other people know about the podcast. Thanks, and we'll see you next time.